Hello, everyone. I think the topic given to me for this particular session, along with Dr. Unni and Dr. Bhattacharya, is what would you do after the patient has got a fragility fracture? What's next? So this particular talk is going to have some mechanistic insights into what exactly is a fragility fracture. Why is it that the bone is involved in diabetes? Links between diabetes and osteoporosis. What further investigation you would actually do when you see a patient with a fracture? How do you stratify these patients with the risk, where the risk could be less than 20%, between 10 to 20 or more? What are the preventive tools that you would talk? Because finally what we want is not to see a patient with a fracture, but we want to see a patient without a fracture where he already has got a risk factors, and also once a fracture there can be a second fracture also. So here we need to prevent that. Some therapeutic strategies depending upon the time that we have. How do you treat this particular bone? How do you tackle the insulin resistance, which may be one of the issues that the bone is getting leached from? And also the diabetes treatment and some futuristic fractures. How do you deal with that? A lot of treatment, pharmaceutical armamentarium, a lot of molecules are upcoming in the next few decades. And I'm very thankful to RSSDI to having given me such a topic. Importantly, the linear increase in hip fracture incidence with increasing HbA1c, as we see the most down with the HbA1c of 6, with one of the abnormally controlled A1C more than 10. And that is where we get an idea about that. Yes, it is not just the heart, it is not just the brain, it is not just the kidneys, or it is not just the heart failure that's the new baby. It is also that 1% of HbA1c that is important, that we need to look into. So to answer the question, what next? Importantly, first look at how much is the HbA1c of this patient, because that itself is going to be one of the important risk factors for a fragility fracture. What about the risk and diabetes? Whether it's a type 1 diabetes or a type 2 diabetes, it's quite high. For any fracture, the HR is 1.3, 1.19 for type 1 versus type 2. Hip fractures, spine fractures also. These patients really literally become like kind of a bubble-filled ball. If they slip or if they fall, that's why prevention of falls is important. So if they slip or fall, they are going to break one of the other bone. Your fracture risk in the Women's Health Initiative in type 2 diabetes for any fracture was 1.2, hips, pelvis, upper leg was 1.46, spine 1.27. And if you look into this commonality, the common chronic metabolic disorders across the world have a quality of life issue on an individual's health. In India, where we have every 7 out of 100 having type 2 diabetes, we may have at least 3 or 4 having kind of osteoporosis by 2050. It's quite a debilitating disease. It's a silent killer, and the cost of treatment is definitely much more than what we would think otherwise, even prospectively or retrospectively, wherein the bone is less dense, susceptibility fractures are more. An important thing to understand is that diabetes is actually one of the independent risk factor for osteoporotic fractures. Prevalence is there depending upon type 1, type 2 diabetes. It's been there nearly in all the population. Even the Asian Americans or the Asian Singaporeans who are there, the fracture risk is different. So what are the risks? Let's look into this particular table. The risk factors that help for developing or which cause osteoporotic fractures, they may be directly due to the diabetes itself, poor glycemic control, that's the first slide we showed, and nephropathy, wherein there is a adynamic also and a dynamic bone disease which could happen in a patient of diabetes with nephropathy and chronic kidney disease. Neuropathy and diabetic diarrhea, where there is a lot of risk of fall versus there is a risk of losing out calcium, magnesium, and phosphorus, and due to concurrent presence of either a Graves' disease, which is again a bone leaching disease, celiac sprue, wherein there is issue with absorption, amenorrhea, the FSH-LH link is out, delayed puberty, eating disorders, of course, anorexia nervosa and bulimia nervosa, and sometimes maybe we do not know, even orthorexia nervosa may cause the bone to become weak, to become fragile, to be osteoporotic with a risk factor, and we know then what needs to be done. The risk of falls are so important because if a patient from a fairly uncontrolled one comes to us, if you are very heroic in suddenly getting their glucose values down, we may land up this patient with an episode of hypoglycemia, and that's a very important factor in the history. So when it comes to next, apart from looking at the control, we also have to look at the risk factor for the falls, where the patient gets up at night for nocturia, poor vision, retinopathy, or cataract could be there, poor balance due to neuropathy, foot ulcer, amputation, diabetic footwear, something is slippery in the house, orthostatic hypotension, which could be drug induced again, which could be diabetes itself, long standing, can cause that, impaired joint motility, and chorioarthropathy, which can cause a lot of associated risk factor to fall, again needs to be considered. And these both, osteoporosis is an endocrine disorder and diabetes as an endocrine disorder, they're both seen very frequently and are interconnected in a lot of ways. As we see here, that there is definite initial adolescent accumulation of bone, and it is diminished by around 20-25 years, wherein the person actually gains the whole momentum of the bone and then gets his BMD by around that particular age, as we see here at number 2, and after 40-42 years or so, wherein the decline happens after even 27-26 years in patients with diabetes. So osteoporosis has got a lot of stages onset, and they could overlap with different types of diabetes at various stages of diabetes. There are many kind of mechanisms that we see with diabetes induced osteoporosis, whether it's a TNF alpha or the rank L molecule, which along with the MCSF may have kind of a all osteoblast derived activators of osteoclast proliferative and differentiation. I think we can talk 2 hours about these mechanisms. This is in short age showing one particular graph wherein the ages itself, the uncontrolled diabetes itself, has issue with the type 1 collagen, bone rigidity, and other in bone quality, the TBS or that score with because of the non-enzymatic glycated induced skeletal fragility. And it is important, that's why in agenda slide we put up that particular word, that we need to look at insulin resistance as well as the HbA1c when you're talking about the non-enzymatic age-induced skeletal fragility. And that's how this literature also on mechanism concludes about the diabetic skeletal fragility to altered bone quality. That's the word that we use. And we need kind of more studies to look into the assessment of biomechanical consequences of this accumulating age. So I will now, from mechanism, will come to what exactly would you do next. We talked about a chart where we saw what history you would take, where we saw what precaution you would take. Now let us look at the goal of what exactly you would do. This particular patient who's come with a fragility fracture, identify at risk fracture, whatever the last column that we showed you in our second slide was that particular patient with the risk of fracture. Prevent the first fragility fracture or future fracture if one has already occurred. So in our given scenario, we're talking about prevention of this particular future fracture and of course treating the current one. Stabilize or increase the bone mass, that's important. Relieve symptoms of fracture and or skeletal abnormalities, improve mobility and functional status. I'm going to show you slides about all these things. Initiate lifestyle changes, slide on this, to enhance prevention of fracture. Now, diabetic therapy itself has action on the bone quality itself, whether it is metformin, which has got some action about increasing the BMD and reducing of fracture. Sulfonylureas, TZDs, we all know in postmenopausal ladies, we would not want to use TZD because there is kind of a data which causes that they may reduce the bone formation and may have increase in risk of fracture. We know the bone anabolics like insulin and GLP-1 analog, which could be neutral versus may actually help to increase the BMD and bone formation mass. And SGLT2, we have some data in the past, some data of the current talking about this particular drug. So a 10-year risk fracture is higher at every level of BMD, whether the T score that we look into is -1, -1.5, or 2, or at 2.5. So essentially what we are trying to tell is that apart from prevention, precaution, and listing the patient with the risk factors and stratification, we also need to have an assessment done by BMD. For example, if the patient is a postmenopausal lady or a man over 50 years of type 2 diabetes and there is a typical osteoporotic fracture, then we need to start on anti-fracture medication. And if the BMD is, if there is no fracture, second time means this patient has already come with one and the score is less than 2.5, again treatment would be given. And if there is too much rapid bone loss on follow-up, we need that trabecular bone score, or the TBS, adjusted fracture probability. We'll show you some slides on this. And of course, look at fracture of spine. When we talk about what exactly is typical osteoporotic fracture, look at the spine, hip, pelvis, or humerus and the clinical risk factors, substitute them with rheumatoid arthritis, advanced age. So this is a very easy tool which is available on our website. If you just put fracs, we will get that. Now look into, let us see what happens after fragility fracture is there, depending on whether it was a male of more than 50 years or less than 50, depending upon the age, or whether it's a pre or a post-menopausal diabetic patient with this complication. Assessment of total number of clinical risk factors, and we need to perform some baseline investigation minimum, which could be either kind of a CBC, which could be either ESR, LFT, calcium, phosphorus, vitamin D, chest X-ray, spine X-ray in some patients, and in some patients this could be mandatory to see whether because the patient may have presented with one fracture but maybe having still one more fracture inside the body. So we need to at times look into history and examination, special investigation as and when needed that we would look into. These could be system specific or organ specific depending upon the age. So for example, a 80-year postmenopausal female or male, you would want to do a myeloma screening, or a patient with a risk factor of pulse, which is more, or the patient has lost weight recently, you would do a thyroid function test. In men, of course, testosterone, because hypogonadism itself is a risk factor, as I showed you about amenorrhea and other slides. Prolactin, PTH, urine BJP, again for multiple myeloma, along with protein electrophoresis, biopsy to rule out malignancies, where depending upon the case, you have to get the baseline DEXA, femoral neck, as well as the lumbar spine. And it may be done within 3 to 6 months after the fixation of fracture, if that was very, very in emergency. And as a diabetologist and endocrinologist, if we are called a little later after the surgery, then we need to look into that. It has to be done. And if the 10-year major osteoporotic fracture probability of this particular patient is calculated, and in WHO Frax chart, this is as easily available as the EGFR that we calculate on our phone. The reference would be the Singapore Indian population, and look at the BMD versus CRF Frax. I want to stress upon one point over here, that people with diabetes do have a higher baseline BMD, but they have a lower score. That's why the TBS, or the trabecular bone score, is going to be very, very important. It's a very important clinical pearl. And always ascertain the disease severity and the type of pharmacological therapy that you would want to use. Depending on that, what you would want to use, also the blood test may differ. So of course, it's a clinical decision making. If the patient has got high fracture fragility risk, which means that here your number comes as more than 20 in the WHO Frax chart, then you would do pharmacological therapy and counseling for lifestyle, as well as non-pharmacological therapy and a DEXA at least at 2 sites, at femoral neck and lumbar spine. This is again an important clinical pearl, that in DEXA, look for the neck and the lumbar spine and not just only at the wrist. Now, that is where the treatment guidance is going to be important, and that's why we move ahead in time and we look for anti-osteoporotic agents, we look for bone forming agents. Vitamin D and calcium, of course, are going to be one of the important prongs that we need to give. Regular weight bearing exercises and avoidance of tobacco and alcohol. And then you may reassess after treatment of DEXA, maybe approximately of around 2 years duration or so. So if you look at the management, if there is a prior fragility fracture, as in the case given to us, or the T-score is less than 2.5, or if there is T-score is between 1 to -2.4 and the fragility risk score is between 3 to 20, then the pharmacological treatment is very, very important. And the case given to us Here, the patient, of course, needs a direct pharmacological treatment and prevention of a future risk. Now, when it is a fracture, generally the thought is that we need to see an orthopedician, but actually when the disease is an endocrine disease, it's a kind of a teamwork where you need an occupational therapist, we need a physical or a physiotherapist, we need an orthopedic surgeon. Depending upon which bone is involved, we may need to call even a neurosurgeon, of course, endocrinologist, and at times maybe a nephrologist, because that's how then we form a team and call upon how do you get into goals. The patient thinks that he needs to maintain or regain the independence, and that's very important. This goal needs to be keep in mind, because the patient needs to be moving, the patient needs to be walking. The physician goal is, of course, as we discussed, what next? So next is to prevent the next fracture. And that is why one of the yesteryears, the theme of Osteoporosis Day was capture the fracture. I think that was a very, very apt theme kept for around 2019. We need to improve the bone mineral density and the TBS, and the patient is thinking that, yes, we should make sure that the treatment is working quickly. But let us understand, there is quickly means it takes 1.5 years for the bone to actually get the strength. Bone and muscle are one unit. Stronger the muscle, stronger the bone also is there. That's the reason we need to have those exercises that the patient needs to be done. Patient comes with the thought that I need to do only bed rest because of fracture, but actually it's not like that. Very rarely our colleagues, surgical colleagues, tell them for a bed rest unless it's a quadriplegic thing, or unless it's a fracture at a very innocuous site where we would be careful in immobilizing or mobilizing. So that would depend upon the case. However, the patient would also have a goal of having a treatment that will give a different fracture outcome, and from the physician side take a different treatment approach to achieve a different fracture outcome. And the patient also should have a goal of having a treatment that is simple and easy to use, because this is again very important. There are various types of anti-resorptive treatments, bone forming treatment that needs to be given. Of course, cost is going to be important, but the cost of therapy always is lesser compared to the cost of surgery, and that's the reason the prevention is better than cure in this particular case of diabetes with osteoporosis. For the physician, it's again provide support to begin and stay on treatment for optimal outcomes. I think this is one of the most important line for this particular talk of what next. We need to provide this support to begin. We need to provide the support to stay on the treatment, and we need to provide the support to have optimal outcomes. Each word in this particular line is what we are looking at, and we need to harp upon our patient and what type of exercise can the patient do. It is usually, as I said earlier, bone and muscle are one unit, and muscle strengthening is important depending upon the site of fracture. For overall health prevention, the exercises would be different, balancing exercise would be different, and weight bearing exercises, of course, are one of the important places where it should be done. And it has, even though it has a small effect, we need to give this particular benefit. It reduces the loss of muscle mass, which is very important for diabetic patients. As they are losing muscle, they may be sarcopenic, which itself can cause the bone to lose calcium and the bone cells, and also will start reducing the risk of falls, which is very important. Improve the balance and strength. Regular walking decreases this particular risk of hip fracture. Importantly, tell your patient about how he has to decrease the caffeine. For any diabetes patient, 2 regular cup of coffee, one morning, one evening, would give less than 200 milligram of caffeine. Anything beyond this is detrimental to heart, detrimental to brain, detrimental to blood pressure, detrimental to bone. So that's why it's a very important history taking about how much coffee you are drinking. Alcohol, you all know how much it is going to be detrimental for the bone. And of course, carbonated drinks are also bone leaching. They are resorptive. Maintaining adequate body weight is very important. Increase in the exercise and weight bearing and balancing exercises. Let us understand that these are the patients who may be nearly kind of 50 plus, or maybe 60 plus, or maybe 65 plus. So be very careful by giving CNS depressing or any kind of a similar drug, or a patient with orthostatic hypotension. Treat visual disturbances, and eye doctor is very important over here to have a clear vision, and of course patient education. Like diabetes, osteoporosis is again one of the important drugs one of the important diseases where drug therapy is important, and we need to talk about patient education. So I think the time given is 20 minutes. I have crossed the time limit already, but I would wait till my chairperson tells me to stop. The pharmacological management, anti-resorptive therapy, as well as bone forming therapy. Usually the thing that is easily available and cost effective and cheap is bone anti-resorptive or the bisphosphonate, which reduces the bone turnover, which reduces trabecular perforations, which increases bone mineralization and reduces fracture risk. So this could be either alendronate, it could be ibandronate, it could be residronate, it could be zolindronate. So alendronate is once a weekly drug, ibandronate is once a month, and zolindronate is once a week intravenous drug, which is usually given in a casualty or a daycare that we would want to give. HRT, of course, there are a lot of varieties that we would give within the first 10 years post menopause. Also, but of course, this is given in consultation with the gynecologist, in consultation with the patient, and we need to give drugs which the patient will tolerate, which the patient will feel happy. And as I showed you, one of the patient goals, it's a discussion between how quickly the patient would come also for follow-up. There are drugs like raloxifene, there are drugs like strontium ranelate, and the newer on the block, which came in around 4 years back, the denosumab. It's kind of an injection. It's again an anti-resorptive therapy, good also for postmenopausal therapy, good also for in patients with kidney disease and osteoporosis, and in patients where the effect of other drugs is not yet coming. The offside of denosumab is it's an injection which is to be given once in 6 months, and of course it's a 60,000 rupees per injection. So that cost needs to be spoken to the patient. Now these were anti-resorptive treatment. Now let us move towards bone forming treatment. Bone forming, one is we discussed in the earlier slide about the muscle forming or the muscle building exercises. Bone forming, we have teriparatide, the recombinant teriparatide, the RHPTH is the one which is one of the best ones to be taken. And there are, of course, a lot of other molecules related to teriparatide which are upcoming. They target bone formation, bone volume by increasing cortical thickness, by improving the cortical bone geometry, and restoring cancellous microarchitecture, and thereby they reduce risk. Earlier, we had studies which talked about that teriparatide can be given for around 18 months, and then later we were told that teriparatide now can be given to approximately 2 to 3 years. That's the upcoming data. But see to it that initially when you give this kind of an injection, the patient does not have postural hypotension. There might be some marginal increase in calcium in the initial few days to weeks. So be careful with that, and also see that the patient doesn't have a background calcium issue where it should not be. With osteoporosis, it should not be a hyperparathyroidism. In those cases, we do not give. So the contraindication should be ruled out. Osteosarcomas also are contraindication to give, not to give this kind of a drug. And we, of course, have the calcium and the vitamin D. And as I said earlier, the insulin resistance and reduction in bone loss. So here is an important line over here. If I'm trying to highlight this, vitamin D and calcium should be along with a tight metabolic control in most of the diabetic patients, and they should have their health assessment to be conducted and continue to prevent fractures. And the treatment for diabetic versus non-diabetic would be similar, but we have to catch them early, treat them early, and give them a good quality of life. And that good glycemic control is definitely having an impact on protective effect, as I showed you in one of the first slides about the HbA1c and the result that we were trying to take from an uncontrolled diabetes. So that's also very important. And management of osteoporosis with diabetes is going to be really to be taken to improve vitamin D levels. Even though that the patient may come suddenly with a fracture, look at the vitamin D. Do not start with directly with an anabolic, because we need to build the calcium. Treating osteoporosis is like treating osteoporosis is like making a wall wherein we have the wall is made of bricks. We have cement in between the bricks, wherein we call it as a vitamin D and calcium. And then there is a plaster over the wall, which could be that we avoid that the bricks do not get damaged. So your brick is going to be more of kind of a teriparatite like of a treatment, which is bone forming, your cement and concrete in between, and then your plaster layers. And to decorate, we have colors and others. And I think with this note, I would like to give it over to the chairpersons. Thank you so much. I'm sorry I've extended my time. I spoke for almost 35 minutes. Thank you so much, ladies and gentlemen.